It's time to get the story behind the story. Interviews with newsmakers, news breakers, and Vermonters making a difference. WCAX presents 802 News with Mark Johnson. Here's Mark.
Regulators are turning up the pressure, particularly on the University of Vermont Medical Center in Burlington, as many Vermonters and businesses continue to struggle with the increasing costs of health insurance. The state's healthcare regulator, the Green Mountain Care Board, recently approved quote-unquote painfully high double-digit premium increases for two major health insurance providers for the third year in a row. In this edition of 802 News, sponsored by Red Hen Baking Company, I spoke with Dr. Stephen Loeffler, the president of UVMMC, about why healthcare costs are rising and how his organization is trying to hold the line. Meanwhile, some observers say the state's entire healthcare system is broken and only years away from financial collapse. We'll begin our discussion with Dr. Stephen Loeffler in a moment. At Red Hen Baking Company, they believe pure, uncomplicated ingredients in the hands of skilled artisans are the building blocks for great food. They're dedicated to creating the best food from the best ingredients. You'll find an ever-changing lineup of delicious pastries, sandwiches, and soups at their beautiful cafe off Route 2 in Middlesex, just off I-89. Their breads are also available in many other locations. Led by owners Randy George and Eliza Kane, Red Hen Baking Company has been on the leading edge of the local food movement since 1999. The first question I want to ask you is the head of the Green Mountain Care Board, Owen Foster, also one of the consultants who's been working with them, Bruce Hammery. They paint a picture of the Vermont healthcare system that it sounded to me almost as though there was too much snow on the roof. And Hammery is predicting, for example, that the healthcare system in Vermont is going to collapse by 2030. As the head of an organization where roughly 1 out of every 3 healthcare dollars is spent in Vermont, is his assessment correct?
I want to give a little background just to start with. So I grew up in rural Vermont. My parents owned a general store. I was the first in my family to go to college. I'm an emergency physician by training. I have been at the University of Vermont Medical Center for 31 years in a wide variety of roles. I got a lot of care in Vermont in my life. My mother, brother, granddaughters have all gotten exceptional care at UVM Medical Center, and growing up, I got a lot of care at Porter Hospital. Right now in Vermont, we have 14 hospitals that deliver great care to their local communities. And we have a system where they can send really sick patients to UVM Medical Center when necessary. There are absolutely challenges in Vermont right now with care delivery. And we do have some affordability issues, which I'm sure we're going to talk a lot about. But if you think about right now, if you're in Vermont tonight and you're having a heart attack or a stroke, or you have a sick baby and you need to get high quality care close to home, you can get it. The state of Vermont, all of us together, have to figure out how to pay for care in a very rural, spread out state to keep our hospitals doing the great work they're doing now. So while there might be a lot of snow on the roof, I'm a Vermonter, I've shoveled a lot of roofs in my life, I think we can get the snow off and make it better.
The question of quality of care, at least from what I'm hearing from Vermonters, is not the big issue. It's really about access to care, a lot of long waiting times, and the affordability question, I think, is probably front and center right in front of all of our faces. But go back to those comments from the head of the Green Mountain Care Board and Bruce Hammery. They paint a very urgent picture. I mean, when somebody's talking about the system being in real trouble by 2030, that's not 30 years off. So do you feel that way too?
The healthcare system in Vermont right now has a financial issue that's big that we have to solve. Vermont is a very unique state in many, many ways because we're small. So if you think about Vermont and you think about health insurance in Vermont, about 1/3, I'm going to give you round numbers, about 1/3 of Vermonters, 200,000 Vermonters have Medicaid. About 1/3 of Vermonters have Medicare, and growing every day, by the way.
Right.
Every day when people become 65, they go off commercial insurance. And Blue Cross of Vermont only has about 183,000 lives. That is not a big insurance company. That's a tiny insurance company. On top of that, Vermont's either the second or third oldest state, depending on what data you look at. So our commercial insurer is insuring a very old population. Older people consume a lot more health care. You consume twice as much health care at age 65 compared to 45, and twice as much again when you're 75. So we have a lot of Vermonters who need care, and we have a really small, older commercial population. I firmly believe to my core that if Vermont, and I mean all of Vermont, the executive branch, the legislature, our regulator, the Green Mountain Care Board, and hospitals and providers come together, we can figure out ways to take pressure off commercial. In 24, I believe about 8 or 9 of the hospitals are not going to be profitable, so that is a crisis. You can't operate losing money every year. Expenses are increasing pretty quickly for healthcare. If you look at the cost of labor, which is 60% of our budget, it's going up. We want to pay fair and competitive wages. Pharmaceuticals really increasing rapidly. There's some miracle drugs out there, but they're very expensive. And space, we talked about this already. A lot of the hospitals in Vermont are old and have done a lot of deferred maintenance because their budgets are tight. So we have to figure out as a state together how to make sure that we can keep getting high quality care here when we need it, like we can tonight.
Okay. You didn't really answer my question, though.
Is it a crisis? We have a financial crisis, not a quality of care crisis. And so I do believe we have a financial crisis, yes.
Okay. So when Owen Foster says that these double-digit increases in health insurance for the past 3 years is a deep fundamental failure in our healthcare system and there's an immediate need for systemic change, you agree with that or disagree with that?
I would add a line that's saying it's a financial failure of our healthcare system. It's not a quality of care. When you say our healthcare system has failed, I fundamentally disagree with that. I think we're providing high-quality care in Vermont. We have to finance it a little bit differently. Once again, think about Vermonters. So Medicaid isn't a great payer, but people on Medicaid aren't complaining about the cost of their health care. Medicare, in general, works pretty well for people on Medicare. If you look at commercial, there's really 3 pools of commercial insurance. There's people that have a large employer, like UVM Medical Center or UVM or the state of Vermont. In general, they have pretty good coverage, and large employers are figuring out ways to make it work. It's challenging, but large employers are making it work. Then there's people that are on the exchange. So there's not actually a lot of Vermonters that are on the exchange, but Vermonters are on the exchange because there's very big subsidies for people that are buying insurance on their own. Almost 60% of those Vermonters get very large subsidies for their insurance rate. There's one pool of Vermonters that has a big problem. Small employers, that pool of people are paying really high insurance costs. It's growing at double-digit rates every year, but it's not a ton of people. It's probably 40,000 Vermonters. We believe we can fix that.
Give me an idea or two. As I mentioned, you're one of the drivers of the bus in terms of costs and expenses. So well, let me start with this. There was the affiliation that was made with Porter and Central Vermont Hospital. Where has there been savings as a result of that consolidation?
What I would say is those small hospitals, the quality of services that have been able to be delivered there has increased. Both those hospitals now have a state-of-the-art electronic medical record. Both of those hospitals now have a state-of-the-art system for radiology images. So that if you go to Central Vermont Hospital tonight or Porter and need to get a CAT scan of your brain, that image is taken there. It can be read at the medical center tonight by our neuroradiology specialist if necessary. The quality of care is higher. We're sharing services. We're sharing IT function. We're sharing HR function. We're sharing a lot of other functions that are behind the scenes. Those hospitals are much stronger now than they would be otherwise. We're also sharing doctors between locations. So it's very likely if you go to one of those hospitals tonight, you might see an ER doctor that works across the network. Same with anesthesia, pathology, radiology. We've strengthened the delivery of care for patients who get care within the UVM Health Network.
Okay, that sounds to me like you're talking about quality again, which, I'm not going to argue with you. That's probably the most important thing. If I was in here talking to you and saying that Vermonters are complaining about the quality of care, then we have a real problem. But again, so where's been the savings?
Let's assume that Porter Hospital didn't join the network. Okay. They wouldn't have that. Either they would have some other electronic medical record now that wasn't connected that would cost more, but instead they have the one that's the system-wide one. They wouldn't have the same PAC system. That's the radiology system we talked about. They wouldn't have the same reference lab abilities that we have. So we've been able to bring those services to Porter much cheaper than if they had to buy them on their own. Through the pandemic, we were able to group purchase enough masks, ventilators, gloves, vaccine to serve everyone cheaper. There's a lot of back-end function that doesn't show up every day that actually makes the care cheaper than if they were still independent on their own. And if you look over the last couple of years, in general, hospitals in the network have financially done a little better because there is some savings on not the patient walking in to see you in the room always, more on the supplies and the behind-the-scenes functions of the hospitals, which is a lot.
Help me understand, why is that small group, as you described them, that 40,000 group, why are they seeing such enormous increases?
They don't have subsidies like the people that are independently buying healthcare on the exchange, and they don't have the power of scale that the large employers do. So we're in this really tight in-between space where they really suffer the full impact of the increased premium.
Okay.
And you asked me how we could impact that.
Yeah.
I think there's a bunch of stuff Vermont could do. First off, there's federal dollars we're not taking right now. There's a federal program that helps bring Medicaid rates up to commercial. We've submitted for that. That would help. It won't be the sole savior alone, but there's federal dollars that many states are taking advantage of that could be focused on this group and make a difference. Second off, the way we buy insurance on the exchange, there's 4 plans on the exchange. There's bronze, which is cheapest, silver, gold, and bronze. Or I might have it off a little bit. Platinum, I'm sorry. We do what's called silver loading. We put a bunch of benefits into the silver plan and make the silver plan cost a lot. We add benefits to the silver plan that are not available in Maine, not available in New Hampshire. Many states don't do it that way. It's called silver loading. The reason you do that is you can pull down more subsidy from the federal government for other people on the exchange, but it also makes the plan really expensive and makes commercial premiums higher, and that cost is passed on to everybody else. That's number 2. Number 3, the provider tax in Vermont that hospitals pay is 6%. That's the highest in the country. That provider tax gets passed on to commercial. There's good reasons to have a high provider tax, help us with Medicaid, but understand that 6% tax increases commercial rates ultimately, and we could think about different ways to manage that, once again, as a state. Lastly, I really think that how we work on, if we really put focus on that smaller group, we could make a difference. Blue Cross has a big challenge. They have to have good reserves to be an insurance company. We understand that. Decisions they've made in the past also have increased rates. Decisions around having a Medicare Advantage program or how they use their reserves or how they do that. I'm not in the insurance industry, but I think they can be part of the solution with us as well.
There's also been another consultant report, Tom Reese, I'm sure you've seen it, who estimates that the network and UVM could save upwards of $235 million. Is that a credible report in your mind? Is that a credible number?
We met with Tom, and I appreciate Vermonters who are out there on his own time doing this work. He's citing that data off something called the NASH, NASH/P report, which looks at Medicare data for hospitals across the United States. And it's called the Medicare Cost Report. There's a couple tricks to that. First off, not every hospital lists all their costs in the same categories on that report, so you have to really dig in and really look at it to make sure that when you compare UVM Medical Center to Dartmouth to Albany to Mass General, that we all accounted for our expenses the same way. And Tom's report focused on, I'm going to tell you now, column 2, which looked at administrative expenses for hospitals. A lot of hospitals do that a little differently. So right now in Vermont, the UVM Health Network runs all the administrative expense for the entire network through UVM. That's not that common in academic systems. So right now, all the network expense, all the shared service expenses that we just talked about, all run through the medical center's budget and payroll, and then all the other hospitals pay their share of that back in. So if you just look at column 2, we look very expensive, okay? A good example, though, is why you have to look beyond column 2 is Albany Medical Center's administrative expenses in column 2 of the NASH-P report is 0. Now, do you actually believe that Albany has 0 administrative expense?
No.
No. If you go across to column 7, then you can see where the dollars get paid back in, and then we're very competitive. We actually pulled some data that I can share with you that shows that, first off, then Albany's no longer 0, and we're no longer the most expensive on the chart. Only a couple academic medical centers in the country run all their expenses through the AMC or Academic Medical Center. In the long run, we should definitely move it out, but it's expensive to do that. It'll cost $3 or $4 million to build a new cost center, to incorporate the network, and we've been focused on other things right now. We've been focused on improving access and adding an MRI machine that people need and a Da Vinci robot, and didn't really want to spend $3 million right now to carve that out. Also, we have 2 states and a bunch of different unions with people that are employed by the network. That work is complicated. So when we carve that out, I won't have to explain this because our column 2 will look like a lot of other AMCs. But right now, you have to look further into the chart.
So that $235 million is imaginary.
There's not much savings in administration. That isn't there, and we showed that to him. So he really came with 2 big things for us to look at. And once again, we appreciated it. We've met with him twice now, and we're going to have a third meeting. We want to look at his data and understand it. So first, he had, I think, I might get the number off a little bit. I think he had $120 million or something in administrative expenses. That isn't real. If you look further into the chart, we were able to explain that away by running it through the medical center. The second part is a little more interesting. He said that if the UVM Medical Center could earn a margin on Medicare rates,
Yep.
that's worth about $100 million. That's also tricky because not every hospital gets the same Medicare rate. So every hospital starts with the same Medicare rate. So if you're going to take out someone's appendix, every hospital starts with the same rate. But then if you're a rural hospital, you get a different rate. If you get a certain wage index for a population, you get more money. If you're a sole community hospital, you get more money. You can have penalties. So the rates that hospitals get for Medicare is different, so the dollars in the door are different. It's very important that you think about actual money coming in, not some percentage. So we are working hard to become more Medicare efficient, but in Vermont, where we provide all the dialysis for the state of Vermont, the UVM Medical Center, we lose a lot of money on dialysis. Most academic medical centers in the country, the vast majority, probably more than 90%, don't own dialysis. It's provided by a private company. All of that loss has to be covered somewhere. That adds to us losing money on Medicare. I could give you other examples, like our NICU. We lose money in the NICU. I think people want to make sure that we have a NICU here. If you have a baby born that needs care tonight, that loses money. Not every hospital has the same spectrum of services and covers the same things. If you own primary care, that can make you lose more money. I already told you dialysis, NICUs. Do you own your own psychiatry, or does someone else do that? All makes a great difference on whether or not you can earn a margin on Medicare rates.
Why are you losing money on dialysis?
The government doesn't pay enough. Almost every Vermonter who has dialysis is either on Medicare, Medicaid, or what's called dual eligible. The rate that we get per day of dialysis doesn't cover the cost of providing it. Doesn't cover the cost of the nurses providing the service. Doesn't cover the cost of the doctors that need to oversee the care. Doesn't even really cover the cost of the machines or the solutions that we use to dialyze people. We lose millions of dollars a year on dialysis.
You mentioned New York. The network has 3 hospitals here in Vermont, Porter, Central Vermont, UVM here, and then there are 3 hospitals in New York. Are Vermonters subsidizing New York, or is New York subsidizing Vermont?
We see thousands of patients a year from New York. Many New Yorkers come to us with commercial insurance, which pays well. It helps to make sure our academic medical center is active and busy. We need that population to have the full spectrum of services that we do. If you look at the dollars that come into Vermont from New York, they far exceed the dollars we spend to have those hospitals be part of the network. It's a net positive every time you look at it.
So I, as a Vermonter, am benefiting from you having these 3 hospitals in New York.
Absolutely.
It's a I don't want to say profit because you're all nonprofits, but there's a net revenue gain.
It's more than just profit. It's more than just money, though. Money has something to do with it, but much more importantly, we can offer specialty services here because in the whole region we have enough patients who need them to make sure we have enough doctors to do that. So, for example, cardiac surgery. If we didn't have the New York population coming here for cardiac surgery, our program would be much smaller if we could even have one. And that I could tell you that story over and over again, that extra volume of patients we get from New York lets us have a full range of services here, that lets us be a vibrant academic medical center, train the next generation of providers, have a great medical school, and attract world-class doctors here to do what they do, take care of people.
I mentioned to you before we started that I watched the hearing that Senator Bernie Sanders put together, where I would say he put together, the big players in Vermont healthcare, the head of Blue Cross Blue Shield, the head of the Community Health Center, Owen Foster from the Greenmount Care Board, a few others. And, one of the things that really struck me was that it didn't seem as though everybody was working cooperatively and together. I mean, right now you've got Blue Cross Blue Shield that's claiming you've overcharged for some procedures. You got the Greenmount Care Board that you folks have just sent a letter to saying that they're regulating you in an improper way. When I step back and I look at the totality of this, I think, some of the key people that have got to make a difference here don't seem to be working together.
Vermont's strength is that we're small and we can work together. And I agree with you right now. We're not working together as well as we could be or should be. I agree with that. I'm not sure that we're all trying to solve the same problem. And so right now, it feels like commercial insurance and our regulators very focused on commercial rates and how high commercial rates are, and that's unaffordable for Vermonters. And I think we should be more focused on how to impact that smaller group of people who really have a problem. And also at the same time, with that, how to make sure our hospitals are here into the future. If Vermonters want to be able to get a full spectrum of services, both in Vermont and the right appropriate services at their community hospitals, we have to figure out a sustainable model going forward. I don't think Vermonters all want to have to go to Boston to have most of their health care. It's inconvenient, it's difficult, you'll be far from home, it's expensive. And the truth is, for commercial insurance, that won't really save them money. If we can't offer certain services here and Blue Cross has to pay Dartmouth or Albany or Mass General for that service, do they really save money? No, and that'll be hard. So I've said this at multiple meetings now, I believe those players you just named, all of us together come together, once again, talk about the federal money that could help, talk about, are we using the provider tax dollars exactly the way we should? Some states use some provider tax money to buy down commercial rates. Is silver loading the best way to do the plans? Is that the smart thing to do? Should we think about what services are included on our health care exchange plan? Another thing Vermont does is for our commercial insurance, we do what's called community rating.
Yep.
It's not a bad idea in general, but I'm 60 years old. My health care insurance should cost more than my 32-year-old son's. In Vermont, for both buying on exchange, our rates are the same. They pool everybody. That makes it very expensive for my son, but a little less expensive for older Vermonters. So there are things we could do as a state. They all have trade-offs. They're all complicated that could make a real difference and allow us to have great care close to home.
So should the Greenmount Care Board look at that and say different people pay different rates? That I'm closer to your age than your son. Let me put it that way.
Yeah, I think we have to put everything on the table And I don't think it's going to be one thing. I want to be clear on that. I think it's going to take a little bit from a lot of things and it's a little bit of trade-offs. If there was an easy solution to this, we'd have fixed it.
Right.
So it's going to be more than just so, and that's part of my concern with what the Green Mountain Care Board's doing. Their total focus is on driving down patient revenue for hospitals. But patient revenue is how many people you see. Patient revenue is access. When you say to hospitals you can bring in less revenue, what you're really saying is you need to see less patients. I don't think that's the answer. The other thing they're doing is saying, we're not going to let you charge commercial rates that are what you need to cover the bills. So at the UVM Medical Center, our bills are going up in 25. Our staff is going to cost more. Drugs are going to cost more. Medicaid is not paying much increase at all, almost nothing. Medicare is going to pay a small amount. And now commercial is not going to pay more either. So how are we going to do it in 25? We're going to have to do something, probably, unfortunately, reduce services. I hate that. I've been here 31 years. I've been the president of the medical center for 5 years. And since I've been here, we've done tremendous work to improve access. And we're still not where we need to be. We still have problems. During the pandemic, when many academic medical centers were closing beds, closing floors, we paid travelers to come to keep everything open because we wanted to serve every Vermonter who needed it. It made us lose almost $30 million in 22. But it was the right thing to do. I'm proud of that. But the cuts that they're going to make to us this year, which still require a 20% commercial increase because it's not just about the hospital expenses, will make us weaker. Will make Vermonters have to leave the state to get care. Will make Vermonters have to wait longer to get care. That doesn't seem like the right solution to me as a doctor.
So what does reduced services mean? Longer wait times? Denial of service? I mean, what are you actually talking about?
So it could be a mixture, and we're not done yet. We just got done with the budget order, so we're starting to plan out what it could look like, and we didn't know what it was going to be. It could be that there's some services that will no longer be available in Vermont. It could be we'll have more trouble accepting some transfers because we won't have a bed available. We'll use less travelers, less overtime or special pay to keep everything open. We might have to take some beds offline. And there are some services you might say, look, we're losing money on this service. We just can't afford to provide it now.
Okay. Like dialysis? What are we talking about?
Everything has to be on the table. I don't want to scare anybody on your podcast. I can commit to you.
I already am.
Yeah,
So, yeah.
I can commit to you that we will do our best to have the least impact we possibly can. But we can't lose money every year and survive. Our patients need to have current modern facilities. We need to have great equipment. We need to pay our staff fair and competitive wages. And so you can't do that if you're losing money.
Go back to the first question I asked you. If nothing changes, is the trajectory correct that Bruce Harmery, the consultant, one of the consultants for the Green Mountain Care Board, says that the system's going to collapse by 2030? Is that accurate?
With no change, yes, we have a giant problem.
Wow. Okay, that's not 30 years out.
No.
That's 6 years from now.
Yes.
Okay. I'm not going to do my Bernie Sanders imitation for you, but so what's your plan? What's your plan on that's a house on fire.
We are doing everything in our power to be as efficient as possible, to get non-patient care expenses as low as possible, to leverage the power of the network to make sure everyone is getting care at the right location, not more expensive sites if you don't need to. There are people that don't have to be in a bed at the academic medical center, could be at Porter or Central Vermont cheaper. We're trying to get more people out to nursing homes. Last week, one night, we had 72 people at the medical center that need nursing home beds that we don't get paid for. Those people have to be able to get back out to nursing homes, so we're doing work with them. And we're doing a lot of work with what's called a population health service organization that really is focused on keeping people healthier. It looks at people who use the ER more than they might need to, or have an issue at home that if you address that issue, they wouldn't have to come in so much. So the best way to save money in healthcare is have people be healthier. Vermont has a challenge. Vermont is old and Vermont is small. Healthcare is expensive for older people. And if you can't spread it among a lot of people with a mixture of younger people as well, then it's expensive. I don't know if you're familiar with the Vermont Futures Project. If you haven't done an interview,
I am.
Okay.
Yep.
for the Vermont Futures Project really looks at growing the population of Vermont. If we
Yep.
grew Vermont and we had more younger working Vermonters, it would really help with this problem we're talking about. A big part of the problem in Vermont right now is our demographic challenge. Our schools are having the opposite problem of us, less children in schools, but still very high costs. We're seeing more patients than ever. If you look at the medical center, between 2019 and 2024, in 24 we're seeing 24,000 new, unique, different patients more per year than we were in 19. Our population is growing. We're seeing more local people in Chittenden County. They're older, they're sicker, they need more complicated care, which costs more. But also, if you look across the state of Vermont, the transfers to the medical center have also grown. In 19, we're getting about 400 transfers a month. Now we're getting 475 transfers per month from across the state of Vermont to the academic medical center. A lot of those people are very sick. They need high-end care from specialists that's expensive. We have to figure out as a state, but I'm confident we can do it, how we're going to keep that care here, or those sick Vermonters are going to have to go to Massachusetts or Dartmouth if they have a bed, or Albany, but they're full most nights. I want to tell you that we have a transfer center every single night. If you look across the region for academic systems, tertiary care beds, specialized care, it's very full every night. We keep track of our how full the hospital is every day. And it's a scale of green, which means everything is great. Yellow means it's pretty tight, but we'll get by. And red means we're going to have trouble today. It's going to be hard to take care of everyone who needs us. Maybe some people are going to spend the night in the hallway of the ER, or they're going to get down in the operating room but don't go to the room right away. In the last 450 days, we were red 275. We were almost never green. We're full every night. I'm really proud of the care that we deliver. And there's lots of data, if you look at Medicare data, commercial data, that shows that we are low cost for what we do. But that doesn't mean it's still not expensive. I'm not saying it's not expensive to get health care in the United States or Vermont, but it's harder in Vermont because there's a small number of people to spread amongst.
Well, and as you noted at that hearing that Bernie Sanders held, you're the one who said that the biggest demographic increase in Vermont is people in that 57 to 62, or I'm not sure I've got
59 to 64.
Okay.
So those people are mostly still on commercial insurance. That's very expensive for our commercial insurer, and they're starting to consume a lot of health care. That group of people is getting colonoscopies, mammograms, biopsies, heart surgery. They're getting total joint replacements. That's expensive. That care is being delivered, and it's expensive for the hospitals to provide it. It's expensive for our insurers to pay for it.
And, you talk about getting more young people here. I mean, that's a whole other can of worms. There's no housing. So, I'm not going to ask you, you got enough problems to solve on your own without trying to solve that, but that's an issue.
It's such an issue for us that we're helping some of our staff get housing. We've added 160 units of housing in partnership with a local builder. We own 49% ownership in those units so that when we have people who we need to come here and help care for Vermonters, they have a place to go. We realized about 2 years ago that we had people that really wanted to come and join us and couldn't find a place to live. So we have housing now. We ask people who move there to stay there about 2 years, and then hopefully over 2 years they find a more permanent house for them, and then it's available for somebody else. But already that housing has allowed us to attract people to join us who we really need here to care for us when we're sick.
You mentioned the traveling nurses, and again, I heard you talking about this at the hearing that Senator Sanders had, that at one point it peaked out at $125 million a year. I mean, I kind of gasped when I heard that, and now you're saying it's about $75 million. Is that something that you can get down to closer to zero?
It wasn't zero before the pandemic. It'll never be zero. There is some amount of traveling nurses that actually grease the system and make it work.
Okay.
If you're going out on maternity leave or paternity leave, you're getting a big operation, you need some time off for some reason, but you want to still have your job, having some travelers helps that work. What I can tell you is before the pandemic, we had 3 to 5% travelers. At the peak of the pandemic, we had 20% of travelers. I want you to know that was a decision that we made to care for everyone who needed us. And it was killing us to pay that money too, but we felt on balance that was the right thing to do to make sure that everyone who needed care came. And large hospitals around us, outside of Vermont, made decisions to not have all their beds open. We did the opposite. We opened more beds. Our traveler expense has come down. Our traveler needs have come down. We've added a net 500 additional new nurses in the network over the past, I think it's 18 months. So we are gaining new nurses every month. We have 150 new nurses starting at the medical center right now.
That's significant.
So we are making progress, but we're not, I don't think ever going to get back down to 3 to 5% travelers. I just don't think Vermont has, we're not graduating enough nurses. We don't have housing for enough nurses. And so that is an issue. And Senator Sanders is very focused on that. We have some great programs at the medical center and in the network to let people, if they choose to, be trained to become nurses, and we pay for that. And we have a lot of other scholarship programs that we're building right now. But our traveler rates, I think, will be high for some time unless we figure out ways to have a bunch of new people move to Vermont.
And you just signed a new contract with the nurses, which provided some, I'm not going to use an adjective, but they seem to be significant raises. But here's getting back to one of the points I made to you earlier. When I was watching that hearing, and then I never thought of this, that the head of the Community Health Services says, well, that's great, you're paying them more, but now you're causing me a financial burden too, because I've got to try to, it's like escalation. And he says, really, the two of you don't really communicate that much. And that's a concern.
So we actually have a great relationship with the Community Health Center of Burlington, and Jeff McKee is their leader, and we talk regularly. The issue in Vermont right now is we're all fighting over the same workforce. So there's a shortage of workers, and so to compete and attract the workforce that you need makes wages go up. I'm confident that we're paying our staff a fair and competitive wage, and we're paying what we need to pay to staff the UVM Medical Center. I do not like hearing from our local other community partners that is causing them difficulty, but it's sort of a catch-22. If we don't pay our staff, they leave and we have to pay travelers, and that has an impact on all of the services we can provide and the expense of care here. And if we do pay them, because there's not enough nurses total, then it causes impacts elsewhere. We were at a little more balance prior to the pandemic. You have to realize that in the pandemic, the same demographic we're talking about, older Vermonters who are working part-time, made the decision to stop working or work even less. And so during the pandemic, the workforce in Vermont in healthcare got smaller. Lots of people either started working less or retired. We have less workers now than we had before, and so we're competing for a smaller pool of people, which drives up wages.
Speaking of competition, I hear some observers say that Vermont hospitals, which are all nonprofits, are competing with one another for patients. Is that a fair statement?
Totally disagree. So my biggest concern on any given day isn't that Copley will take a patient from us. It's that they don't have beds available to keep the people who need to stay there. Every single weekend, the UVM Medical Center does 30 to 40 operations every single weekend from people being transferred in across the state because the service they need isn't available on the weekend where they are. So Vermont healthcare system is a fragile system altogether, and the medical center needs everybody to have their beds up and running and have the appropriate services there to keep any Vermonter in their community that they can. We're not in competition with any other hospital in Vermont at all, and I believe they would tell you the same thing.
One of the issues that you talked about, too, was primary care, and there's a feeling that too many people are getting care in the emergency room downstairs when they should be going to a primary care doctor. I know UVM has, and I may have the wrong term, but grouped up, taken over some primary care throughout Vermont. And why? I mean, and has it worked? Has it made it? Owen Foster, the head of the Green Mountain Care Board, I was blown away. Who said that he had to call 8 different people. This is the guy who's the head regulator of healthcare in Vermont, and he can't find a primary care doctor. Need I say more?
First off, UVM Medical Center provides less than half of the primary care in Chittenden County. Community Health Center of Burlington, Evergreen Health, Thomas Chittenden, all other small private practices actually combined provide more primary care than we do. We are not seeking out any practices. We are not trying to attract people in. There are practices that said they wouldn't be able to survive unless they joined us in the past. We brought in those practices, but we never were out advertising to join us. Across the state of Vermont, there isn't enough primary care across the state as a whole. And so in some parts of the state, people do go to the ER because that's their only access to primary care. We see that some in our emergency department, but not that much. There's enough primary care in general in Chittenden County that people can typically see their doctor. We recognize there is primary care access issues, though, and we're adding 3,000 additional spots for new patients in fiscal 25 in primary care at the UVM Medical Center across our practices.
Is primary care like dialysis? Is it a loser?
Yes, it loses money.
And why?
It loses money because the cost of it's a couple things. The cost of the staff it requires to provide the care. The staff expense is high for the care that you deliver, and it's not, healthcare in general pays better for procedures, pays better for getting your hip replaced or getting an MRI or a procedure or heart surgery, and pays less for your doctor to do a great job keeping you healthy and doing a good physical. The money's just less for those things. It's essential. It's critically important. It's what Vermont needs more of, and that's why we're going to do more of it. But yes, we lose money on it.
And I think you've just identified what I would identify as one of the fundamental problems with healthcare in this country. You're nodding your head, which is
I don't disagree with you.
Yeah.
In the system that we have, healthcare, I can tell you, running a hospital, we subsidize all kinds of things here every day. So there's relatively few things at the UVM Medical Center that actually make a margin. There's lots of things that we do that lose money, but our mission is to provide the full spectrum of services that we possibly can for Vermonters. We want every Vermonter to be able to get the care they need here, close to home. We want to be able to accept transfers. But many, many things we do here, the neonatal intensive care units, psychiatry, primary care, many pediatric specialties, lose money, but they're the right thing to do. They're part of our mission. They're part of taking good care of Vermonters, training our medical students and residents. And there's a relatively small number of things that earn a margin. And that's part of this challenge with the Green Mountain Care Board as well. What we charge for those things that actually make a margin help cover the cost of everything else.
One of the things that you mentioned, too, that surprised me was the amount of money spent on prescription drugs. I guess it shouldn't have surprised me. You talked about it being 20% of your budget. You know, again, talk about a passion of Senator Sanders. My goodness, I've heard him talking about it for 40 years. And, you know, he noted that the 10 largest pharmaceutical companies made a profit of $110 million last year.
Billion.
Billionaires. Why can't you negotiate a better deal on prescription drugs?
We negotiate what we can, but even though we're big from Vermont standards, we're tiny from hospital standards. So we have great supply chain leaders, we have great pharmacy leaders, and we do a really good job of getting the best deals that we can. But drugs that we use are really expensive. And I told in that meeting with Senator Sanders, we do this amazing new cancer treatment here, which is unbelievably incredible for Vermonters. They can get it close to home, not have to leave the state. The drug costs $500,000. Most of our insurers pay a very small percentage of that, $150,000, $180,000. They don't even cover the cost of the drug. So right off the bat, we're going to lose money in that care. But once again, it's the right thing to do to close to home if we can do it. The problem with budget changes and really squeezing out the dollars that we can make on certain procedures is you'll have to stop doing things that lose money. That's what's going to happen in Vermont. Vermont hospitals will be forced to stop doing stuff that loses money.
You know, I know people that have taken some of these drugs, and you go to the pharmacy and you say, wow, you know, this is an incredible amount of money. There's a zero copay. And the pharmacist says, well, what do you care? You're not paying any money for it. And my response to them would be, we're all paying for it.
We all are paying for it. We all are paying for it in our commercial rates. We're paying for it in our taxes, our Medicare rates. We're paying for it.
Okay, I'm feeling another 6 inches of snow on the roof when I hear that. I mean, there's really there's nothing you can do about that. Is that what you're telling me?
No. So I want to go back to where you started. You say, is the system in Vermont going to collapse? I teach medical students and residents quite a bit. And what I say all the time is, look, if you're really sick, you want to be in the United States of America. We provide the best care in the world, the highest quality care in the world, the safest care in the world if you're really sick. If you need heart surgery or a lung transplant or you need large invasive surgery for a big trauma, there's no place in the world better than the United States of America. But it's very expensive. If you want to pay for health care, you want to be somewhere in Europe where they provide a lot of money up front to keep people as healthy as possible, but do a lot less of those services. How do we take the best of Europe and keep people a little healthier, make those investments so that down the road costs will come down, but not lose the amazing care that we deliver here every single day? But I'm a believer in Vermont. And our numbers are small, which is a challenge, but it's also a power because we can figure out how to make it cheaper for those 40,000 Vermonters. We can figure out how to keep our small hospitals strong enough to take care of their local communities, keep those beds available so that we don't have to have everybody at the medical center when they don't need to be here.
So how do we change that trajectory so that, I mean, you're in a business that seems reactive. So I get sick, I come to you. But, the American healthcare system is very good at that, but it doesn't seem to be as good as many European countries at preventative care. Is it because the government is involved in subsidizing it? What's the difference?
We already talked about this a little bit. The American system incentivizes hospitals and providers to do procedures, but we are shifting. So at the UVM Medical Center, I just told you that even though it'll cost us money, we're going to open up 3,000 more spots for primary care patients in Chittenden County. We've developed a large organization to help keep people healthier, to keep them out of the ER, to help keep them not have to be admitted to the hospital. If they are admitted when they go home, be able to stay at home. We're investing in home health, hospice programs, palliative care programs, ways to keep care cheaper. That alone won't fix the problem, but that's an investment in our future and having future costs be less.
You mentioned 8 of the 14 hospitals were in the red. Do we need all 14 hospitals? People talk about wanting to not close them, but turn them into different kinds of facilities.
I'm pretty confident we need something in the communities where they are now. It might look a little different. The services might look a little different. But we have to be careful because the Academic Medical Center, UVM, we're full almost every day. Our ORs are full every day. Our inpatient beds, the amount of transfer we can take is pretty much full. So we have to make sure that we have enough beds distributed across the state to care for everybody. Having more nursing home beds open will help us. And we want to make sure that when Vermonters go to their local hospital, there probably is an ER there 24/7, probably can stabilize their problem, diagnose a heart attack or a stroke if they're having it, start appropriate care there. At times they'll be able to do the whole care there. And also when they can't, get them up here and we have capacity for them. So I do think they might look a little different, but for most people, I think it'd feel like you'd be able to go and see your primary care doctor. You might be able to see certain things in your community. There would be an ER there. You would have an urgent care there. Your primary care would be there. And then there'll be services available depending on the size of your community that make sense for that community.
What keeps you up at night?
It's an amazing gem to have an academic medical center in a city the size of Burlington or a state the size of Vermont. The UVM Larner College of Medicine is one of the oldest medical colleges in the country. I was fortunate to go there. And it attracts world-class physicians to practice in Vermont. We have people here that would take care of you or I tonight if they needed us, and they're only here because of the academic teaching mission that draws them here. But if there wasn't a medical school here, and you said tomorrow, let's pick the next state and city to build a medical school, it wouldn't be in Burlington. We're too small. And it costs a lot of money to have a medical school. It costs a lot of money to train residents. And I've heard people in Vermont say maybe we can't afford that, or maybe it's not something we can afford, but I think we can't afford not to do that. Over the last 3 years, more than 100 residents who trained at UVM Medical Center have stayed in Vermont. Many of them stayed outside of the UVM Health Network. They've gone to Newport, they've gone to Brattleboro, they've gone to Copley. We are training nurses, doctors, respiratory therapists. We're doing research protocols here. We had COVID vaccine trials here. We're doing a Lyme vaccine trial right here in Vermont right now. I think that's a huge value to Vermonters. I think having that ability to have that in a small city like Burlington, a small state like Vermont, we could lose that if we're not careful. And we will lose a huge part of what makes Burlington, Chittenden County, and Vermont great if we lose our academic medical school.
What does the Green Mountain Care Board not understand that you understand?
I think we're trying to address the same problem. They're very, very focused right now on the affordability of healthcare, and I understand that is a real crisis. But it's only one part of the issue that we have to focus on. We have to focus on making sure we have strong healthcare system that's able to survive challenges, that there's dollars out there to invest in our workforce. We have to make sure that we're keeping our facilities modern. If you or I go to the hospital tonight, we want to be able to get care in a modern facility that's safe and clean, the right equipment. And so the problem, I think, is bigger than just affordability. And if you only focus on affordability, I think you could erode the system to the point where it'll be hard to recover.
And just a couple of questions on accessibility. As you know, getting an appointment for dermatology, for example, is months. Urology, from people have told me, is also a real problem area. I'm sure there are others. What can be done? Is that the same issue? Is it the same challenge, the same problem?
We do have access challenges. I will say that the whole United States, for certain specialties, does have access challenges, not only Vermont. It's sort of what we've been talking about this whole time. So if you look at Chittenden County is really the one area of Vermont that's growing and also getting older. And the UVM Medical Center is both the community hospital for everyone who lives locally, but the tertiary care hospital for everyone that gets referred and sent here. And we have not grown fast enough to manage the local growth plus the referral growth. That 24,000 new patients per year we're seeing, the increase in transfers, that means we don't have enough urologists to care for everyone in the state who needs us. And we don't have enough dermatologists for the growth in Chittenden County, especially when Chittenden County's older and more of us need a dermatology visit. More of us have a rash to look at or a spot. And so we have space challenges that impact the access we can provide, how many offices we have. We have space challenges in our OR, which is why we're trying to build an outpatient surgery center. We have staffing challenges. In many specialties, we can't recruit enough dermatologists. If we could even recruit more urologists, I don't have enough OR capacity for them right now or office space. But we're doing a lot of work on that. So one of the huge values of the network being together and the small hospitals being part of this and the electronic medical record that we use is we can do something now called e-consults. So you see your primary care doctor, they identify a problem that in the past they would have called a specialist to make an appointment for you, and it might be 4 months, as you just said. But now with an e-consult, they fill out a consult on the computer. It goes to the specialist. In less than a week, the specialist reads the consult, makes a recommendation, sends it back to your primary care doctor. It's in your record. You can see it. More than 90% of the time, that answers the question. It's cheaper for you. It's much faster. It opens up specialty access for people who do need to see that doctor, because that doctor could also say, yes, we need to see Mark next week. Here's the appointment slot. And we've done more than 4,000 of them last year. So that's 4,000 people who didn't have to see the specialist. So it's opening up capacity for others. There's lots of things that we're doing like that right now to improve access, but it's still a challenge.
One of the other issues Senator Sanders and I think a lot of Vermonters bring up is this whole question of what do people like you get paid? He mentioned there are 10 people who in the administration who get more than $500,000 a year. Why can't you find people that are dedicated to the mission for less than that?
We try to pay every person who works at the UVM Medical Center and the network fair and competitive wages. We try and pay our environmental service workers, our transporters, our surgeons, our nurses, and our executives wages that are competitive in the market. When I came back to Vermont, there was a Vermont discount. When I came back to Vermont in 1993, doctors that worked in Vermont made less money because you wanted to live in Vermont. I wanted to come home. I wanted to raise my family here. We're in a national market now. When you put out wages for any position, whether it's doctor, nurse, technician, any position, they compare what they could make here to Connecticut, to Boston, to New York City, to Texas. If we don't pay fair wages, we will not have a workforce. We see it every day. Also, Vermont is not a cheap place to live right now. Vermont housing is very expensive, food is expensive, cost of living here is high. I don't think we're going to solve this problem by not paying people. If you actually look at the amount of dollars that we pay our administrative leaders, it's 0.16% of the budget.
Yeah,
it's a rounding error.
Yeah, no, I know. And you said the same thing at that meeting, and Senator Sanders said that, you are avoiding the issue.
I believe I just gave you the answer that I believe. We should pay everyone who works here fair and competitive wages that puts them on the benchmark for that position nationally. And I still think there's positions in administration here that we're underpaying compared to what many people could make at lots of other locations.
What I'm hearing in the course of you talking to me is that it's not an expense problem and that reducing costs is not going to be the solution here. That really there's almost, I'm hearing an inevitability because of the demographic, because we want more people to live in Vermont, that if anything, this $2 billion is going to just keep going up.
If we're going to take care of older Vermonters who need care, it's going to cost more. We're going to have to figure out how to care for people who need care in this state. We can do some things to manage expenses. We can do some things around the edges to bring expenses down. But if we're going to provide a full spectrum of services in Vermont, it's not going to be cheap. That's the truth. If Vermont chooses not to provide all the services, either Vermonters won't get them, I guess that could be cheaper, or they'll have to travel. Vermonters who are able to do that can travel out of state. I'm not sure how much money that's going to save either. We have to figure out how to make commercial insurance more affordable. I believe we can do that. I believe there's things, none of it will be easy. There's ways to do that. And there are different ways to pay for health care that the federal government's looking at now. The AHEAD model in Vermont, if that model had a good reimbursement rate for all the things we talked about, preventive health, keeping people healthier, that could be a great option for Vermont. I'm not sure yet. I want to see more of the numbers. I don't think we're going to be able to take huge amounts of money out of the system. I do not believe that.
That wraps it up for this edition of 802 News, sponsored by Red Hen Baking Company. Thanks for listening.